So Pat, I'm going to hand this the screen control over to you.
Okay.
Just before I start doing my introduction here. There we go. Sharing. So I have shared it to you. Perfect. Okay. So thank you everyone for joining us in person and online. If this is your first meeting or not, we're really excited to have you here participating to collaborate, engage, and learn with and from you. I'd also like to extend a thanks to Rick Hansen Institute for providing not only this meeting room here in Blesson Pavilion in Vancouver, but also for providing the virtual meeting space through WebEx so that we can really make these meetings available province-wide. For those of you who don't know me, my name is Melissa Ashman. I'm the Education Director at the Cancer Prevention Center at UBC, and I'm also the meeting chair for this chapter. Today's presentation will be recorded, and the link and slide deck will be made available. And following the presentation, there will be 15 minutes of Q&A, which will not be recorded. So if you're listening online, we ask that at this time you please mute your microphone if you haven't already until we reach the Q&A portion of the presentation. So I'm now delighted to introduce Pat Atherton, the project manager of InspireNet, who is presenting virtually through WebEx from Vancouver Island. If you haven't heard of InspireNet, be sure to go Google them after this meeting and go check them out. They have some fantastic resources and are a great organization. They're BC's Health Services Research Network, funded through the BC Nursing Research Initiative of the Michael Smith Foundation for Health Research. In her role with InspireNet, Pat supports KT initiatives for over 3,600 network members in a mostly virtual network, virtual work environment, leveraging Web 2.0 and web conferencing technologies. Pat has extensive experience working to develop KT capacity in BC, using technology to bring people and their ideas together across geographies, disciplines, and institutions. We're delighted to have her present today on mobilizing knowledge to improve health services. So Pat, over to you. I'm just going to, here in Vancouver, I'm just going to rotate our camera to the audience.
Excellent. Thanks so much. I'm just going to check. I have a lovely view of the fluorescent tubes in the room. If you wouldn't mind adjusting the camera down just a bit so those of us in WebEx land can actually see the room. Perfect. Thank you so much. Oh, now we're seeing the floor. Great. Hi everybody. Greetings from Victoria. I'm going to stream my video just while I make a couple of introductory remarks. Then I'm going to turn my video streaming off so that you can focus on my presentation. So thank you, Melissa, very much for the warm introduction. Melissa's actually taken care of my first couple of slides for me. So I just wanted to say welcome, and I hope that you find this informative. And with that, I'm going to somehow stop streaming my video. One moment, please. Okay. So as Melissa mentioned, InspireNet is a program of the BC Nursing Research Initiative funded through our good friends at the Michael Smith Foundation for Health Research. Funding commenced in 2009 and will end later this year. And before I press on, I'm just going to check my sound level. Is everybody able to hear me okay in the room?
It's a little quiet here in Vancouver.
Is everyone able to hear me okay online?
Yeah. Okay.
Sound is good online.
I think we need to check in with somebody named Jenny Lease, who's got some background noise going on. Are we all good? We can all hear? I'm going to assume we can. So InspireNet is working to create and share health services research knowledge, strengthen research and knowledge translation capacity, and facilitate innovation in delivery of health services. I'll just give you a quick background or an overview of what the presentation is going to include. I'm just going to check to see if Jenny's noise is affecting anybody else. Can anybody else hear that? Or
Under the pen? Oh.
Somebody want to mute?
Sorry, your entry is not valid.
Somebody want to mute Jenny at the Vancouver side? Thank you. So the overview of the presentation includes the history and background of InspireNet. I'll talk a little bit about how we developed a KT action plan. I'll describe the KT initiatives we have underway through our network. I'll describe the evaluation activities we've undertaken to take a look at how effective those KT initiatives have been. I'll share with you some of the critical lessons we've learned through our heading into 5 and more years at this point in the life of our network. And I'll also provide you with some supplemental resources to refer back to afterwards that might be helpful. So with that, we'll get onward. The network had a soft launch in 2009, and it was fully operational by spring 2010. We've had a couple of extensions to the grant period, which was to have ended October 31st, 2013 originally, but we have been successful in applying for extensions through the Michael Smith Foundation. The original mandate was to increase nurses' capacity for and interest in health services research across BC. And for those who don't know, health services research is defined as the interdisciplinary study of factors that impact the quality and cost of healthcare and ultimately public health and well-being. A cross-cutting theme was supporting interprofessional approaches to health service delivery, and our mandate grew to become interprofessional in year 4, which is when we moved to our new branding of InspireNet 2.0. With a mission to reach health professionals, researchers, and students in diverse and geographically dispersed locations, it was agreed early on that a virtual network was needed from the get-go, and we knew from that there would be a learning curve for our members and for our leaders. In the planning phase, the decision was consciously made regarding the leadership and operating model, where we would use volunteers and a very small staff of 1.2 FTE. Our leadership model attempts to bring together leaders from practice and from academia to share responsibilities leading our teams. Our network is co-led by Noreen Frisch, who's the director of the School of Nursing at the University of Victoria, and Grace Nicholson, who's academic director at PHSA, or Provincial Health Services Authority in Vancouver. So you can see with that shared leadership model, 1 person in Victoria, 1 person in Vancouver. We would have to do this virtually. We couldn't do it face-to-face. We have an annual budget of about $250,000. So at 5 years, we're 5 years on now. Our network is active with over 3,600 members, which came as a bit of a surprise to us. Back in 2010, we held a leaders retreat where one of our more senior leaders with networking experience in the US projected that membership of this network could number as high as 2,000 to 3,000 people. And we shrugged and thought we'd have a couple of hundred. And here we are 5 years later, and she was more than right. We had no idea that we would achieve this kind of success. 3,600 represents about 5 to 6% of the entire healthcare workforce in the province of British Columbia. Of the 3,600, about 64% work in the health sector. So that means about 64% of those 3,600 are clinicians working in hospitals and healthcare settings. And that brings KT close to care through InspireNet. We organize our network into a number of teams. Currently there's 47. 11 of them are like mini networks of topic-specific content. So for instance, one team looks at e-health, another looks at palliative care. And these teams excel at KT. I'll talk more about them in a minute. We also host 29 research teams that leverage our platform for collaborating on research projects, and I'll tell you a little bit more about them in a minute as well. We also have 7 teams that coordinate operations for the network, such as our conference planning team and our evaluation team and our KT team. We are mostly virtual with our platform, the hub of our operation. However, we have held one face-to-face conference each fall, making us not 100% virtual. Members report appreciating the chance to meet face-to-face at our annual conference, but they love being able to connect virtually without travel required, which is especially beneficial for our members who are not located in the Lower Mainland and don't have travel budgets. Our e-platform is comprised of a Web 2.0 site supported by web conferencing, which we use WebEx just like we're using on this call. Web 2.0, for those who don't know, is the same notion as social media. So everyone who is a member of our network is a contributing member in our organic and flat network. Membership is free, and if you're involved or interested in health services research, please join us. There's a Join Us form on our homepage, and we'd love to have you join the network. And thanks, Melissa, for that earlier plug. So on to KT. That was the background on the network. Now I'll get into the nuts and bolts of what we're here to talk about today, and that is knowledge translation. So we use the guiding principle, knowledge translation, using research to improve health, which is a modification of Michael Smith's definition of KT. They use using health research to improve health. And in our discussions, we decided that we would use any research to improve health, not just health research. So we've modified their definition slightly. We formed a KT coordinating team in our early days and named it the Knowledge to Action Team, and it's co-led by Grace Mickelson, who's also a co-leader of the network, and by Anastasia Maladou at the School of Nursing at the University of Victoria, again in that practice academic shared leadership model that I spoke of earlier. In 2011, we invited key stakeholders to participate in a strategic planning meeting to look at KT options, and this led to the KT Action Plan, which in turn led to expanded KT initiatives. I'll just interject here. You'll see sprinkled throughout my presentation photographs, and those are actual real live network members doing actual real live networky things. So the KT Action Plan includes existing KT initiatives and built on the ones that we had at the time of planning, built on those and put them into the CIHR framework using their nomenclature and ideas of synthesis, dissemination, exchange, and application, which we use to describe our activities. The KT Action Plan includes 4 broad goals with activities within each. So goal number 1 is to develop KT skills for members. Goal number 2 is to optimize the website as a key vehicle for KT. Goal number 3 is to improve the number and quality of contacts and connections to facilitate KT. Goal number 4 is to remove structural barriers, improve incentives, and be the go-to place for nursing health services KT. And the KT Action Plan can be located at this URL if you decide you want to take a look at it. And you'll see a photograph of Bev Holmes from the Michael Smith Foundation, the back of Gail Scarrow's head, and Ann Sales, who's one of our senior leaders located at Ann Arbor in Michigan. So that's a bit about our KT planning and how we got here. Now I'll take a look at the specific initiatives, and I'll describe how they work and try to provide some metrics to illustrate their impact or their uptake by our members. Our website is Web 2.0, so anyone can contribute to the site without special webmaster skills, which is also what we're working on for the BC KTCOP WordPress site. So the kind of things I'm going to describe that we're doing in InspireNet are going to be mirrored to some degree in some of the new things we're doing with our COP, of which you are a member. It was determined early on that our website is not simply adjunct to the network, but is foundational to the network's ability to operate. Therefore, we built a content-rich and active website, which is constantly changing. The site is powered by Drupal version 6, and we use Drupal's organic groups for our team, and Lucene as a robust search engine to locate content in our content-rich site. We contracted a developer here in Victoria to develop the site and our members' database, integrating the two. Database integration means posts link back to the member's profile. Members can find one another easily through this integrated platform, and our database includes members' contact information, their research interests, or practice expertise if they're in a clinical setting, their research and or evaluation projects, and any gray lit they want to share, getting it off bookcases and into use via our searchable website. Through the organic groups, teams are provided password-protected spaces, which we call electronic communities of practice, or ECOPs. Only team members can access their ECOP content. The website has fresh content uploaded daily, and there's a metric of the impact of our website. We've got about 500,000 views since the site was launched in 2010. And there's the URL if you want to go there, and there's a screen grab to show you what it looks like. Supporting our website activity, we develop and distribute an electronic newsletter. The e-news includes freshly curated website content such as funding, research skills, resources, conferences, new research articles, announcements, etc. The e-news is circulated every 2 weeks to all members and is archived on the site. We use MailChimp, a third-party mail service, for e-news distribution. This has improved our delivery rate as mail servers generally allow MailChimp mail to get through, unlike mail that comes from non-mail servers. We have found that our website hits measured by Google Analytics spike immediately following e-news distribution with its embedded links to new content. And we have so far distributed 130 newsletters, and there's the archive if you want to go back and read any of them, and that's what they look like. As mentioned earlier, InspireNet includes 3 types of teams with their own ECOPs. Action teams are topic specific and are open to all InspireNet members. Closed teams are research teams, and they're open only to their team members, and coordinating teams support the work of the network. Here's a link to learn more about the teams. And there's 2 network members doing networky things. Teams use ECOPs for their work. As mentioned, ECOPs are password protected for team members only, and they include discussions, webinar details and recordings, wikis, and document sharing. Teams use their ECOPs in different ways. So action teams use them for networking with others and for professional development or knowledge uptake, whereas closed teams use their ECOPs for research project development and then for knowledge dissemination. Some teams have more than one ECOP, as different groups do different things within a team. So while we only have 47 teams, we have 79 ECOPs across those teams. More network members doing networky things. There's Diane Finegood from Michael Smith Foundation, Noreen Frisch from InspireNet, Sherry Hamilton from PHSA, Monica Redicott from Vancouver Coastal Health and Sales from Ann Arbor, Michigan, and Sharon Strauss from Toronto, all experts in KT in their own ways. Our blog is available on the open internet, and we invite members to write posts on issues related to health services research and or KT. Comments on the blog can be made and viewed by InspireNet members only. Our blog has been read over 20,000 times, which surprised us, as health services research we thought was not a large community, and this count grows over time. So I'm just going to take us away from my PowerPoint and over to the website and show you what the blog looks like. So this is the web page where the blog is housed. Because I'm logged on, you can see things on this page that you wouldn't see otherwise. And one thing you can see is the number of reads. So this blog page has been read 20,240 times, which surprised us. We also have functionality where I could add this to my own private library. So it's like a bookmark, and I can go back and find this web page later on when I go to my library and read it later. So I just wanted to show you very quickly a couple of posts so you get a feel for the kind of content we have on our website. Here we've got a post written by Anastasia Malady, KT, What's Next for Healthcare Professionals. It's had almost 3,000 reads. This post is very interesting. Nurses, how can practicing nurses get involved in research? This is written by Sabrina Wong, who's a faculty member at UBC, and her post has had almost 4,000 reads. So that kind of uptake surprised us. We thought we would put up a blog and it would get a couple hundred hits and we'd get on with our days, but we found that when a post goes up, this counter just continues to go and climb and get uptake by people across the web. So that was an interesting lesson that we learned. An innovative idea developed by InspireNet is that of our e-posters. So I mentioned we have an annual conference, and we intend for that to be an entry-level event. We try to balance providing a collegial environment while being appropriately academically rigorous. The e-posters provide an opportunity for members to gain expertise and experience in presenting their projects before submitting them to a larger conference, and thereby we're building KT capacity, we think. We put out a call for abstracts annually, which are peer-reviewed by network members so that they can gain skills in the area of abstract review. And then successful abstracts are developed into full electronic posters, which are displayed at the conference using large screen monitors for synchronous viewing. We post the poster links on our website for later asynchronous viewing and dissemination. Authors are invited to do a webinar of their poster after the conference, which are then recorded and archived. From our evaluation work, we know that the e-posters initiative is highly valued by our members because it's a unique opportunity in BC Health Services research. No one else provides this kind of opportunity. And the photograph we see here is an exemplar of a couple of our members demonstrating their electronic poster from last fall's conference. So they have it on a small laptop at their display station, and then it's broadcast on a large monitor. Like most of you, I hope, we're using social media in our network operations, specifically Twitter and Facebook. And we use Hootsuite, a Vancouver company, for easy aggregation of our channels, a little plug for a company that I think is doing good work. Our goals in using social media are for knowledge dissemination, such as tweeting out a new research paper. We also recruit study participants for our members' projects, this to a lesser degree. And most importantly, we tap into streams of fresh web content, retweeting and posting to our website, providing a central repository of new materials for our members. We mostly follow the hashtags BCHC for BC Healthcare, Canadian Health, and Health and Research. So there's some ideas for you. If you're not currently following those, you could if you wanted to. And here are some metrics and our usernames if you want to connect via social. We are at InspireNet BC, and on Facebook we have a page called InspireNet. We see more uptake via Twitter than Facebook, which others in healthcare have also reported, and I think that's probably because of professional guidelines around Facebook for personal use versus professional use, especially in the nursing community. Another innovation from InspireNet is the Ideas Incubator. Here, a clinician completes a web form with their potential research question or idea. So you're working away and you realize you have a question that could be formulated into an evaluation idea or a research question, and you have nowhere to put it. You have an idea, you need a place to put it. We've given clinicians a place to put that idea. So a clinician can complete a form. InspireNet then posts that idea to a public web page with a link to the submitter's database profile, and then researchers are alerted to the new question or idea via our e-news. And here's a link to the Ideas Incubator page, and I will take us over to the website and show you that as well. One moment, please. So here's again our website, should be looking familiar by now. This is the Ideas Incubator page. You can see we've got research ideas submitted by members, and the submitter's name is here, and you'll see it's hyperlinked, which is that integration of database and website that I mentioned earlier. I'm just going to do a little very short demonstration of how that works here. We see Anastasia Maladou, who is a member of our COP, has submitted an idea looking for colleagues to work on this research project. So I'm just going to click her name, and that will take us to her database profile. So you can see the kind of data we collect for our network members to find one another and to search on one another. So for Anastasia, we see that she's in Victoria, that she's got a website, we've got an avatar for her, she's got a UVic profile. We see that she's available to mentor. She's also looking for a mentor. She's looking for students. We see that she's maybe got some volunteer opportunities for students. So these are all fields in our online database that any member can search on. So if you're a student and you're looking for volunteer opportunities, you can use a filter on our database to find any member who has volunteer opportunities. Likewise, we collect data on whether you're a graduate student or an undergraduate student, what kind of nurse you are, what kind of researcher you are. We also, as I mentioned, collect data on your research interests or practice expertise if you're a clinician, as well as your future research interests, and this helps individuals to find collaborators on projects. We provide space for a short bio, and we also provide more details on our members. So for Anastasia, we can see she's an assistant prof at the University of Victoria, and prior to that, she was an adjunct at U of A. We can see that she's submitted a project under the Health Services Researcher Pathway. So this would be a research project that was funded through the Michael Smith Foundation for Health Research in 2012, and all of these are hyperlinks, so we can find all projects that were funded by MSFHR. We can find everyone who worked on the Health Services Researcher Pathway. by clicking these links. We can see all projects that were funded in 2012 by clicking that link. And we also have a piece of gray literature that she's submitted and the organizations that were involved in the preparation of that gray lit. And again, those are all hyperlinks that we could click to get everybody else who's in or affiliated with those links. Finally, in a member's profile, we can see all the teams that an individual belongs to. So you can see that Anastasia is an extremely active member belonging to all of these teams within our network. The final initiative I'll highlight today is that of our webinars, and they are of the highest value of all initiatives according to our member surveys and interviews. Our webinars are recorded with links available on the website, either in an ECOP for team webinars or on the homepage for webinars open to all network members or the general public. There are 3 types of webinars. Action teams put on topic-specific webinars for their team members, or in some cases, for all InspireNet members. Our Lunch and Learn series are KT topics presented by members to teach KT skills over a lunch hour. And the 3rd type are the virtual podium type, and those allow our members the opportunity to present a webinar on their own project. So they're able to disseminate their knowledge doing a webinar through InspireNet for free. We do coaching, we do promotion, we organize the webinar, we record it, and then we archive it. So it's a nice opportunity for members to be able to disseminate their knowledge. Through our evaluation work, we know that our webinars are by far the highest rated of all initiatives. Part of this is the accessibility of the format, with members able to tune into a webinar at their leisure. They no longer have to travel for their professional development, nor do they have to attend in real time even. Presenters like that they can present from their home or from far away. We've had presenters from as far away as Sweden and Australia. So here's some metrics on our webinars. We've learned from our metrics that there's a 6-to-1 relationship of asynchronous versus synchronous participation. Asynchronous participation is limitless when embedded in a virtual network with a web platform, so the metrics on webinar recordings continue to increase over time, expanding the reach of each. And here's a link to a recent report on our webinar experience. We're currently publishing on this experience because it came as a surprise to us as well. I think it's probably obvious, but if you don't know, synchronous means in real time. So you are all participating in this webinar synchronously. And if you were to watch the recording, you would be participating in it asynchronously. So that's that language. So I'm just going to take us over to the website again one last time and show you our webinar recordings page. So we've got those 134 webinars that have been organized by our various teams and held by network members are in one central repository on one web page on our website. So members can come here easily and find topics to learn about. So suppose you need some professional development credits, you could come to our website and get those. We've got them broken down by those that are open to the general public, those that are open to all InspireNet members, and those that are open to action team members only. So you need to be a member of a specific action team. These are the action teams, to tune into any of those. So that just gives you a feel for the kind of webinars that are held and have been held over the past 5 years. So to recap, InspireNet supports, as CIHR describes, both integrated and end-of-grant KT. Our integrated KT initiatives are the website and database for finding collaborators, gray lit, and recruiting study participants, social media for recruiting study participants, teams for collaboration, e-news for recruiting study participants, and the Ideas Incubator for bringing clinicians' questions to researchers. And end-of-grant or knowledge dissemination occurs through our webinars, through our use of social media, through the e-posters initiative, through the blog, through the teams, and through the e-news. And how do we evaluate all of this activity? Because there's no point in doing it if you don't know that it's making a difference, right? We have a comprehensive evaluation plan and a logic model that were developed back in 2009. We work in partnership with UBC's eHealth Strategy Office, where they have expertise in evaluation of electronic communities of practice. So we have an annual contract with them, and we work together with them in partnership. Surveys and interviews have demonstrated a clear value for our members, and Google Analytics help us understand traffic to the website and to individual pages. So we can do some refinements, some course correction as we need. We're also able to use these data for demonstrating our value to our funder, the Michael Smith Foundation for Health Research, and to our public. And here's a link to our webpage that includes all of our performance reports. So our latest evaluation completed last summer. We had a series of interviews and focus group sessions. Showed 4 themes emerged as the network matures in its 4th, going on 5th year of life. 3 of those themes relate directly to KT, those being learning new research skills, providing new tools for conducting research, and presenting and disseminating research. And we thought those were very interesting to see as the network matures. Thanks to our members' input into evaluation activities, we've been able to illustrate value, and that's resulted in increased membership, as I said, exceeds our wildest expectations. We did not anticipate having 3,600 and counting members. We also were very pleased to be able to have extended funding because we were able to illustrate the value that we're adding to healthcare in the province of BC. And the evaluation we've done around KT has helped us to develop potential partnerships for life after funding from the Michael Smith Foundation. And those photos you see are just screen grabs from WebExes and one from the website from past activities, just to see networkers doing networky things. Here are some exemplars from our evaluation activities from our members to help get a feel for what members think about the network. It was InspireNet that inspired me to return to a master's program. Through InspireNet, I have learned how to participate in an online research community. My action team brings everyone to my doorstep. InspireNet eliminates barriers such as cost and geography to provide opportunities for individuals from across the province to connect and learn. I have been in psychiatric nursing for over 40 years and see this as a new era and direction of nursing in the future. And I am thrilled to build a community of practice that will allow me to assist frontline staff. And there's some smiley, happy network members. So I promised I'd share some key lessons with you from our experience. We've had some significant bumps in the road as we've figured out how to do virtual networking. The foremost lesson we've learned is that a tech-savvy professional is required for day-to-day management of the network for its success. And in this case, that role is held by me. And I manage the e-platform, the related vendors, staff recruitment, training. I build the e-platform with a contractor. I curate members and content in social media. I support the team's startup and training to work in a virtual environment. I troubleshoot their onboarding. And I collaborate with the leaders to advance the virtual network, to go to new places and to help them work in this brave new world. The second area we learned is critical is that of facilitation. So I mentioned that our leaders are volunteers. They also require significant help to do that facilitation piece. They work to develop the team's mandate and welcome new members and drive the content and activities of the team. But leadership requires individuals who not only have an interest to learn how to work and lead virtually, they also have to have the time to take on this work. So we've had a number of keen members take leadership roles only to find that they didn't have the time to learn how to work virtually or the time to do that kind of facilitation. So it's not like you turn it on and people come. Which leads me to a well-known rule in online communities, and that is the 1-9-90 rule, also known as the 90% rule or the 1% rule or any other permutation of those numbers. This metric refers to online communities and suggests that 90% of users are lurkers, and that means that they read or observe but don't contribute. And if you are a member of any kind of online community, you know who those people are. You might be one yourself where you feel more comfortable just passively participating, reading what's going on, not posting anything, not contributing, just tuning in, and there's value to that. 9% of the users contribute from time to time, but other priorities dominate their time. They do find some time to get into the discussions and to contribute things. And then there's those super users, the 1%, and they participate a lot and account for most contributions. It seems as if they don't have lives because they often post just minutes after whatever event they're commenting on occurs. So we've learned that it's important to support super users and contributors. You might think that you would want to spend time fostering relationships with the 90%, but they're going to get benefit as a lurker or through peripheral participation, which is the more polite language that's being used. But focus needs to be on the 1 and 9 to really build a robust community. So we've learned that virtual platforms aren't enough, that support is required, and that support needs to go to that 1 and 9. And we presented a poster last year on this. The link is available on a later slide. It is called, "If You Build It, Will They Come? Lessons from a Virtual Health Services Research Network," where we outline the kind of lessons we learned about just building it. This isn't going to get them to come. You have to actually do significant proactive work to make sure you've got an active online community. And we'll find that with our COP on its new website over the course of time. And this leads me to the notion of community management, or the role of community manager. This might be a new concept to you, or you might be well acquainted with it, but it's an emerging discipline that looks at the unique role of those of us managing online communities to ensure their success. We know that setting up a website isn't sufficient, and that communities need to be fostered in order to get traction and to be effective. And I recommend, if you want to learn more about this, especially those of us who are going to be in leadership roles with the BC KTCOP, to look up Rich Millington and Feverbee, his organization, to check out thecommunitymanager.com and follow #CMGR in your Twitter streams, where there are ongoing discussions about the challenges of herding cats, managing online communities. So our latest evaluation reiterates excuse me, that a virtual work environment is different than other ways of working. The 3 things that stood out for us in our latest evaluation is that a virtual work environment takes time. Participants noted that it took longer than expected to get members comfortable using the technology. And in our first 2 years of evaluation, that was a constant theme, that people didn't feel comfortable. Even people who had experience with tech and felt they were a little tech savvy and had a smartphone still took time to get them engaged in working in a virtual work environment. Then from there, we learned that it can be done. You know, once we got going, using technology can be used effectively and with ease, and people started to recognize that it's becoming the way of doing business. And finally, in our last year of operation, we've discovered that it has a snowball effect, where participants are noting for the first time that once they start to use the platform for one thing, they're using it for everything. So we've got a number of teams and members who are very active using our platform and wouldn't be able to do their jobs in BC Healthcare without it. So here's a very short list of the publications and informal reports links that we have prepared to date. We have more publications in process. These are available on our website, and of course they will be in the slide deck that will be going up on the website, so you can access these at your leisure. And as promised, a small sample of online resources that have been curated over the course of the last 5 years relating to KT and virtual communities. And if you want a full list, you can contact me. My contact information is down here at the bottom of the slide. And once the COP's website is live, it will be very easy to find one another. It will be a lot like finding someone in the InspireNet database. So that concludes my presentation, and I think we are opening this up for questions now.
chat. I didn't want to adjust the, there we go. So that wraps up the Q&A. Pardon me. That wraps up Pat's presentation. Thank you very much. At this time, we will be ending the recording of the presentation and beginning the Q&A. For those who are listening online, we invite you to unmute your microphones and start asking questions.